Hey everybody, and welcome back to another edition of the Physiotutors podcast. Today I'm speaking with Lars Avemarie, a physiotherapist, a lecturer, personal trainer, a writer who's focused on the betterment of the treatment of people with chronic pain. Now, Lars, why don't you give us a quick 1-2 minute intro for the listeners to yourself, and then we can dive on in.
Yeah, so first of all, thanks a lot for having me. That's a real pleasure. So basically, I've worked full-time in the health industry since 2006 and worked multiple roles. I've worked as a fitness instructor, as a receptionist, as a gym class instructor, even as a mid-level manager. And previously, I also worked as a self-employed personal trainer, where I specialized in exercising with people who have chronic pain. And this was all before I went to university to take my bachelor's degree in physiotherapy. And currently, I work full-time in what we could call sub-regional rehabilitation, and have done that for some years. Then on the side, like you talked about, I teach weekend course internationally, where I try to reimagine and reconceptualize the management of people with pain and chronic pain.
Okay, that's great.
Yeah.
Pain, then obviously it's quite a complex topic, a complex issue. I'm not going to ask you to try and break it down and explain what's happening at the level of the brain with the inputs, the outputs, and everything. But when you're working with your patients, or if you're running your courses, or if you have students, how do you describe pain to them in that clinical setting to help them understand what's happening with their body, whilst not bombarding them with science that may go straight over a patient's head or a student's head, or might not just be appropriate to throw science and see what sticks? How do you go about that?
So when I started learning about the neurobiology and the neurology and psychology behind the lived experience of pain, I was very enthusiastic and very passionate about the topic. And I really wanted to, like you said, bombard all my patients with all this new, amazing knowledge. But like you talked about, I've soon realized that it goes way over people's head. People are really not interested in science or having a lecture. So basically, lecturing to patients, I did for a long time until I realized that that is really not preferable. But my current way is to use Socratic questioning, using questions that force reflection and try to explore alternative solutions and meanings behind the pain. And those meanings and metaphors and explanations should all validate the patient's own experience of pain. So basically, if we take a more neurological and neuroscientific view of pain, we can, in many cases, much better explain to the patient what they are experiencing than they can themselves using a biomedical or biomechanical framework. So basically, our understanding currently validates to a much higher degree their own experience than the old ways and the old purely biomedical and biomechanical way. That could be somebody saying that they had a flare up and then exploring what really happened with the flare up and at the time of the flare up. They may believe that that's because of a discus prolapse that they have had for 10 years. And then you sort of explain, but what do you have pain now? No, that was yesterday. Yesterday was a really not a good day for me. Okay, so what do you think happened to your discus prolapse today, since you have almost no pain today or have much less pain? Is it gone today? And then they start trying to reflect upon it. They can come to some conclusion, which many do, that it's often also worse is if I sleep bad. Okay, so now you're saying that sleep actually also impacts your pain. Yeah, and if I'm stressed, then it's not a good day. Okay, so often the patients themselves actually have a more broad view of pain underneath their beliefs, but they only act upon the more biomedical beliefs. Does that make any sense?
So basically, you're helping to guide them through by asking these questions and get them to come to their own conclusions.
Yeah, what pain is. And normally that validates their experience because it explains why they one day can have very much pain and the other day almost no pain. Or they can be at a 10 one day and then one day after they can be at a 5. If that were supposedly explained by some sort of tissue damage, then they have a problem explaining, what could we call it, changes in the level using a model that is purely about issues with the tissues. So the body doesn't just break down when you wake up in the morning. You have been sleeping for 6 hours or 5 hours or 10 hours, and then you wake up and then the whole body is broken. That doesn't make any sense.
Absolutely. So then, while you're taking them on this guide and you're getting them to come to these realizations, you mentioned you use a specific type of questioning to get them there.
Yeah. So this is called Socratic questioning. That's like the one of the founding or fundamental principles behind the cognitive behavioral therapy. And that's, I think, it is categorized into 6 different types of questions that actually all of them are on a different subtopic, but they try to force or interfere with automated thinking. So often we are on a fixed path in our thoughts and in our view of what is happening, but those beliefs can sometimes are not concurrent with what we know about pain in most cases. So I never had a patient come to me and I talk with them about what do you think this pain is that you're experiencing? Could you explain to me what it is? Then I haven't had a single patient say, well, pain is a multifactorial, multi-dimensional experience influenced by multiple factors. No, they don't say that. No, they don't say that. They say, well, it's a discus prolapse, it's my knee, I got operated, it's my old hip, it's my old knee. And then I ask them, well, how old is the other knee? Well, that's funny enough, the same age. So often it's based upon a firm and fixed belief that is by large perpetuated by health professionals and our environment.
So, what are the themes or the main 6 themes of the Socratic questioning?
Okay, so that was a very good question. I have them written down someplace here. So there's 6 types of Socratic questioning. So the first is question for clarification. Why do you say that? Then there's a question that probes assumption. Then there's a question that probes reason and evidence. Then there's a question that talks about viewpoints and perspectives. Then there's a question about that probes implication and consequences. Okay, so you're saying that you have a discus prolapse. What are the consequences of you thinking that your body's actually broken? And how does this match that actually right now you don't really have that much pain as you had yesterday? So that's probing assumptions and implications. And then the last question is the question about the question, come into reflecting upon the question. Well, now we talked a lot about this. Why do you think I ask you the last question? Why do you think that I think that that is important?
Do you ever get any pushback from your patients when taking this approach? Who, yeah, sometimes you do get those patients who come into clinic that want everything to be spelled out for them rather than be guided
Yeah,
through. Do you ever get any of
yeah,
that in the clinic?
yeah.
Or yeah,
I get those all the time also. But from my view and my perspective and my experience, I get a lot less of this pushback if I first seek to gain a good understanding and a good, what you could call mutual agreement, or a good solid therapeutic alliance. So if the patient from the beginning, or before I start to tell them what they should do, which I would normally advise against, most patients don't want, like we don't want to hear what we should do. That really doesn't help. But if I get them to understand that I want to do as much as humanly possible to help them get better, that's my main topic. I have no agenda. My agenda is to guide and help them using the best possible knowledge we have currently to get them to become better or to fulfill their goals or what it is. And if I do that first, then the pushback becomes much less.
okay. So what sort of patients is it that you then deal with? Your chronic pain patients?
When I worked privately, I had mostly people who walked in from the street and had pain, chronic pain, but not much than chronic pain. That's basically shoulder pain, knee pain, of course, low back pain and neck pain, stuff like that, when I work privately. But where I work right now, I get a wide range of patients, and most of them have some sort of functional disability also, meaning they can't walk properly, they have problems with, they have musculoskeletal problems also, not only pain. Maybe they need some assistance in guidance, or they need some means of help, or they just need to be rehabilitated from their hip fracture. So it's a wide range.
So how would you go about assessing them? And let's say if we just take the chronic pain patients for now.
So pragmatically and clinically, I use the ABCDEF and W framework for the psychosocial factors. In more complex cases, I use a biopsychosocial multifactorial pain anamnesis, which I actually just totally made up myself. So it's basically a lot of questions with the main purpose of trying to explore every single facet of the painful experience. So basically, there's a Greek philosopher said you should leave no stone unturned. And I'm a firm believer in that approach when it comes to pain, because there's so many facets of the pain experience. So we should really try to uncover all of the aspects, all of the biopsychosocial aspects of the pain experience. So that's basically doing a movement-based assessment. What hurts, what doesn't hurt, when does it hurt, how does it hurt, what is the quality of the pain, not only the quantity. Many talks about the level of pain, but they don't talk about the qualitative aspect of pain. How does it feel? Do you often have pain in the night, or is it in the morning? How do you sleep? Do you have any worries? Why do you think you have this pain? What do you think is the reason for pain? How is your stress level? How is it? Is it at work? Okay, you're at sick leave. How many? For how long have you had sick leave? Or how is it at work? How is it at home? So trying basically to create anamnesis question base that tries to uncover every possible aspect of the painful experience and uncover every possible influencer we know from modern pain science that can influence pain. And then if I want something with higher validity, then you could use multiple questionnaires, like the pain quantification scale, the Tampa scale of kinesiophobia, like DASH21, like Starback screening tool, like the Epworth sleepiness scale, or the Pittsburgh sleep quality index, or there's multiple questionnaires you could use. And normally I use the questionnaires, but I fill them out with the patient. So I don't hand them out, but I fill them out.
It seems like your assessment, yeah, you mentioned you do some physical aspects of it, the movement quality and stuff, but it seems like a lot of your assessment is very much grounded on the anamnesis side of it to really grind down into what's going on with that patient and how they feel about what's
Yeah.
going on as well. Would that be right to assume?
So not so much the movement quality, but more, yeah, movement quality is a bit of a loaded word. So I would rather say just movement, how they move, look how they move. Are they in a sort of protective mode when they are moving? How do they move? Are they controlled? Are they anxious? And also evaluate what is the movement related to. Is it them trying to play golf and they can't do golf, and that is severely reducing their quality of life because they love playing golf? Their whole life is going to golf vacations with their wife, and they have been doing this for 10 years, and now all of a sudden they can't play golf? Or is it something they do at their work? So actually they're a soccer trainer or athlete, and actually they can't do their job because of the pain. So basically trying to look at all the facets within the movement and what the movement they are supposed to do that they can't do because of pain. A lot of pain is often movement based, even when static, it's movement based. So try to uncover all the facets. I don't really use any special tests because most of them is a very low clinical value, sadly, especially when it comes to not functional properties, but pain.
I don't know how much time you get to have with your patients there, but obviously there's a lot that you're exploring. Now, how do you then deal with drawing lines in the sand of what's relevant, what's not relevant, while still letting the patient explore everything that they feel that they need to talk to you about? From what I hear, you're covering virtually everything within the patient's life at that point in time, which, if you're using the biopsychosocial model, is the way you should do it, right? You should look at all the aspects, all the facets in that person's life. However, if you're truly going to do that, time is going to be a big constraint.
Yeah, but in my view, actually, it could be a perceived constraint if you try, and often if you try to talk with people about it without they have given you permission to ask the question. So again, actually, we go a bit back to the therapeutic alliance. So basically, there's some data suggesting that people actually will tell you their main complaint and their main story, if you could call it that, why they are here, why they are seeing you within approximately 2 minutes. So basically, what I advise people to do at my courses and clinicians is to basically do nothing the first 2 minutes. If you do nothing the first 2 minutes, then most people, I think it's about 80% of people, will have told you their main complaint, why they are here. And that will actually, paradoxically, actually help you to gain a great deal of therapeutic alliance because they have never been listened to. We have research showing that people talk about, I think it's like 15 seconds before they are interrupted, and they never get to tell their story. They never get to tell what they have on their heart or chest. So basically, we should keep our mouths shut up much more in the beginning of the therapeutic encounter. So actually, to better our treatment and better our therapeutic alliance with our patients, actually we have to do nothing. Sorry, back to your question. so basically, I draw the line in the sand. What is important, what is not, is basically I have sort of two hats on, if you could say it that way. One is what is important to the patient. What does the patient want? And then the other hat I have on, that's what the patient needs. And they could sometimes be the same, but often they are not. So I try to make a plan that adheres to fulfilling both their need and their want. And their want can often be sometimes counterintuitive towards what they actually need. So basically, I want to run a 5K and I want to run it as fast as possible, but I have knee pain. Okay. And I really want to beat Paul from work, because if I lose, I'm gonna wash his car in Speedos outside the firm. So I'm really not wanting to do that. That's why I have now been running and having knee pain, excruciating knee pain for 3 weeks. So basically what they need is to stop running, to stop reinforcing the pattern of pain associated with running. By default, if they keep associating pain with running, they will not be able to run pain-free, because they are sort of recycling and reusing and reactivating this pain neurotag that is linked to running. So actually they need to stop, but that's not their want. Their want is they want to beat Paul from work. So sometimes we have to like deal with that. And that's where I feel we have a huge potential in being able to use our knowledge about psychology to guide them, to advise them, to help them make better, more informed decisions about their care.
I think what you're getting at there with that example, not letting them condition themselves to associate pain
Yeah,
with the activity. So take a moment, take a break, and then almost like hitting a reset in their brain so that the next time they do that activity, there's less pain associated with it, thereby not consolidating what they've been feeling over the past however long their
yeah.
pain has been going on. Now, how much then do you let that patient's pain dictate your treatment style, your treatment, the therapy that you use for that patient?
Can you rephrase that question?
How much do you let the patient's perceived level of pain dictate the treatment?
If we think about one of the basic neurological laws, which is neurons that wire together, fire together, neurons that wire apart, fire apart, meaning that I actually, if the goal is to play golf and not having back pain, then I should not play golf having back pain. So some people, they can differentiate between they are sore, they are uncomfortable to a certain degree, but then when the threshold increase, then they get pain. So pain and flare-ups will happen. I tell all my patients that's inevitable, because we have to push the limit sometimes. We have to test how their tolerance is. And when we test the tolerance of the system, then pain will happen. So flare-ups will happen. That's normal. But there's a big difference between accepting that flare-ups will happen and helping the patient to deal with flare-ups and helping them so they know what to do when a flare-up happens, and going purposefully in towards the painful experience. Normally, I don't do that.
What is it in your clinical decision-making process then that makes you take one approach over the other? Because let's take Paul, the example that you gave earlier of the guy that wants to run and beat Paul from work. You said, right, you have pain when you're running. We're going to take a break from running for a moment. And then with this golfer, you're then teaching them how to deal with and move forward with the pain.
So in both instances, both the golfer and runner, I would normally try to see if we can sort of calm the system down and see how severe their adaptations towards pain is. So normally my go-to intervention would actually be nothing. So basically try to stop the system, try to make them stop making the movement that hurts, and see how, you can't call it stressed out, but how severe the adaptations are to the system. Then we could refocus doing some other type of movement. The funny thing is often the movement that creates pain is very, very context specific, meaning they can squat without knee pain, but if they walk or run, then they will have knee pain. And from a structural view, that sort of makes sense, but then again, sort of not makes sense the other way. So if we believe there was some severe tissue damage, then the severe tissue damage will affect basically all movements of the joint, not only one. And sometimes it's really funny because then they can do apparently exercises that are at least of the same load, but because you load it differently and because it's in a different context, then it doesn't hurt. Sorry, that could also be a means of an intervention where you actually try to manipulate the threshold and the force vector of the exercise or the context of the exercise, the way of loading the body. David Butler, he talks a bit about this in Explain Pain, like doing a similar movement but in a different context, or doing a almost similar movement in the same context. So you can manipulate those.
So you're modulating the pain experience for the patient then, would you say?
Yeah, and trying to find out what modulates it. Could touch actually just be a modulator? Is touch or sensory information a powerful enough modulator that it can impact it? Could the context be modulating so much that it actually helps? So trying to see how severely they are impacted. So I have had some patients with complex regional pain syndrome, CRPS, and the mere thought of doing a movement of the painful limb created pain. So basically just thinking about doing a movement. The adaptations are so severe that in this case, even the thinking about doing a head rotation actually created a sensation of pain. And there's some research from Mosley's group that actually confirmed this, where they had electrodes trying to find out if there were any motor activity, and there were no motor activity, but people got pain from the painful limb or area. So those are some of the most problematic patients.
Would you then treat that in a similar method where you'd look to how you can modulate the pain for the patient?
Yeah, so basically she got my chosen intervention with her because I couldn't do any movement. I couldn't palpate. I couldn't do anything. I couldn't touch her. She would not allow me to touch her. She was very, very fearful. She had been in a car accident 3 years prior and now had chronic pain from the neck. So basically I started with imagining head rotations, like visualization exercises. And then after a while, we could graduate. When she could do that without having the painful sensation in her neck, she actually started doing small rotations. And then we increased it drastically. And then while I tried to influence and help her dealing with all the psychological ramifications of living with chronic pain for 3 years, like stress, anxiety, her job situation, all of this, and a severe case of kinesiophobia and fear avoidance.
So you're not just looking at the aspect of the problem of what they came in with, but the surrounding elements as well. So the psychological factors. How are you then approaching and dealing with that? As we're not trained as psychologists, as physiotherapists, how are you taking that and developing on that further with your patients?
So there's a lot of great papers on what is called psychological informed practice, and that is the way I have been, what could you call it, trained. After my bachelor degree, I did a course with Tamar Pincus on psychological informed practice, and then there's a lot of material courses on it. There's actually a course from, let me see, no, I don't have it here. A course from a big university in the States on psychological informed practice. And psychological informed practice tries to bridge the gap between severe mental problems, the biomedical model, but in between there's fear associated with movement or catastrophization or not depression, but having, what could you call it, problematic thoughts related to movement and related to, having pain. And we as physios should be able to deal with the psychological adaptations and ramifications of having pain.
Yeah, I agree.
But our education is lacking in that part. It is. But there are many courses and resources out there that we can learn. There's even some papers from the 90s talking about doing psychological informed physiotherapy has the potential to make physiotherapy much, much better.
I wanted to ask you this a little later on, but seeing as we're there already, alongside that, what other aspects do you feel that physiotherapists are falling over at this point in treating people with chronic pain?
Basically, how I see it, like you mentioned before, there's the problem of the psychological part that we are totally missing, mainly due to our education, but also due to we are being spoon-fed the idea that we should find an error, then we should correct an error. So basically, one of the big holes is in chronic pain management is that it's still about finding errors and finding issues with the tissues and correcting those issues, even though we, one, don't have solid evidence that the issue actually is with the tissue, and two, we lack evidence that we actually even can correct the issue. So that is one of the big holes. We need to, basically we need to read a lot of, we need to not make pain simplistic, but we need to accept that it's way more complex and that we're dealing with a complex system with many individual factors and individual parts. And actually that could hugely increase the quality of our treatment, because instead of having one thing we can dial upon, we can try to manipulate, being movement quality, movement duration. We now have many different parts we can try to manipulate, and it's supported by research, meaning that pain is not straightforward. Pain is complex and it's influenced by many different parts. So we should try basically to adopt a multifactorial view of pain, because it also gets us much more possibility to help our patients. And also, of course, it's the ethically right thing to do, basing our treatment upon what we know about pain right now.
You've got this approach and you're going to be working with the patients, trying to modulate their pain, finding new movements or other movements that will potentially be around a similar way of what their pain is. Are there any modalities or anything that you use alongside your treatment?
So basically, I try as much as possible to not be focused on one single modality, but actually I try to basically let the patient's goal, representation, and needs dictate what modality I use. So let's say it's like it's a shoulder patient who has shoulder pain and he likes to play tennis. But basically my modality is strength training, and I tell him to stop playing tennis. He should go up to the gym. He doesn't have a gym membership. He doesn't like to be indoors. He doesn't like to be at a gym. But what I say, my intervention is that he should be up in the gym that he dislikes. He should stand in the corner and he should do some funny exercises that nobody else does in the whole gym while standing in the corner. That's really not a good solution from a patient-centered view, because I'm forcing him to do something that he does not value, that he doesn't like, that he's not happy with. So maybe instead it could be giving him some warm-up exercises and giving him some exercises with a rubber band, or even with the racket that he can do before he does his tennis match. and maybe coach him to say, okay, maybe you shouldn't, this next week, we shouldn't try not to play like 1 hour matches, but maybe you should do some technique training, and you should try to reduce it to 30 minutes technique training. And let's see how that works. And then working on all the other aspects at the same time, reassuring him, testing him to see if there's any pathology. And like with most people with shoulder pain, you can't differentiate from the hurtful shoulder to the shoulder that doesn't hurt. Both are equally fucked up often, but making him doing a thorough test, if it comes negative, which it in most cases does, then really assuring him there's nothing wrong with your shoulder, nothing structurally wrong, but you are having pain in your shoulder, and that could be due to many different factors. In making him realize that, then I would use Socratic questioning and I would use metaphors.
Are there any passive treatments that you'd use alongside your...
No, I use totally active approach.
Okay.
Sometimes I could use guided movements, but mostly I use it to see how ramped up their system are towards having pain. So that could basically be, okay, they can't do any shoulder movement without pain. Okay, can they do it slowly? No, they can't. Can they do it while thinking about something else, while saying their own name backwards? No, they can't. Okay, can I do the movement of on them without them doing it? No, I can't. What are the restrictions? What are their passive range of motion? What are the active range of motion? And how is the pain when I try to manipulate those factors? And then I could use, I hate the term manual therapy. I would more say it's more stimulating or facilitating. And in some cases, with more movement-based pain, pain that's more of a nociceptive origins, that could indicate that you do some sort of facilitating or stimulating. That could be movement, assisted movement, but it could also be guiding the movement with the patient. But it's not, one of the main problems I have with manual therapy is that it's often done with the wrong narrative, with the wrong sort of communication, for the wrong reason, and with a wrong belief. So basically it's about correcting some movement that is wrong. We can't say that. We can't say a movement is specifically wrong. Yes, it can hurt a movement, but that doesn't necessarily mean that the movement is wrong. And we really can't say that your movement quality is this way and that is correlated with pain. The research on that is really, really lacking. So we can't say it, not currently. The narrative of doing anything manual, the focus should be on getting the patients back to being active themselves. That's always my focus. And if you should be doing something manual, it should be trying to facilitate pain-free movement.
What is this guided movement? If I came to you with chronic knee pain, let's say, what would a guided movement be?
That could be me guiding your movement with my hands in some sort of way, facilitating the movement, but it shouldn't be facilitating the movement with the idea that I'm correcting it, but more that I'm just guiding and helping.
Might not be the best example, but if you notice someone is, well, you may not like this example at all, as they're squatting, their knees are going in and you don't specifically want that, and you just have your hand on the inside of their leg and you wouldn't be pushing it. It would just be a sort of try not to touch my hand as you're moving kind of thing.
Yeah, that I have no problem doing guidance with my hands and facilitating movement in a different way. The main problem I have is telling people that how they move are wrong. Doing a certain movement will cause injuries and or pain. But I could definitely be hands-on. As a personal trainer, you are very much, and one of your greatest tools are your hands in correcting exercise. So yes to that, but no to having them believe that they should squat like me, and everybody should be in all my patients should be able to squat exactly like me. No, they should squat the way they feel is best using knowledge of biomechanics
Okay.
and with a purpose of maximizing power output. But then we're talking more about performance and not pain.
But this person has come to you and they have pain with that particular movement. So surely that would tell you that there is something about this movement that is now triggering an issue. So there's kind of two ways that you could go about it. You could say, okay, this is a temporary issue. So we're going to introduce another way to do the movement, and then you can fall back into your old habits once the initial pain is gone. Or
Mhm.
you could say to him, no, that's completely wrong. You're only going to do it in this way. And I think that's what you're saying that you don't do and you won't do with your
Yeah.
patient either. And I suppose the third option there would be to let them continue doing the movement the way they're doing it as it's painful and not potentially correcting the movement at all. Now, that's kind of what I'm hearing at this point.
That depends a lot on the movement and the severity of the problem, and also how easy is it manipulated. So basically, you could do the approach that you stop them making the wrong movement, or the movement that in our context not is wrong but is creating a painful experience. Then you have to, at some point you have to reintroduce the movement, and then that could take weeks or it could take 2-3 days. That depends on how their response is and how easily. It could even be that you just divert their attention, or they do a similar but different movement, like instead of doing a back squat, they actually just do a scissor squat with the bar in the elbow joint. So basically, just changing where the load is, the exercise almost is the same, but because you change how the load is applied to the body, that could take the knee pain totally away. But then they are actually doing the same movement, basically. Or it could be a rack pull, where you are drastically changing the force vector. The pulley is coming from the ground, and they're holding a rope between the legs, but they're still doing sort of a squat-like pattern. And then, of course, there's some people with pain where almost any movement that is just somewhat similar to the painful movement will create pain. And then you have to really maybe take a while to refocus on other things.
How do you then help a patient manage their own dips? Because let's say you've got this person, you've modified their movement, you've got them moving in a way that's more pleasant, creates less pain for them. And let's just go with back pain. They wake up one morning and all of a sudden it's been, in one moment, re-triggered. They don't know what's happened. They were for 3-4 months almost pain free, and it's come back. And they think, the patient comes back to you and says, Lars, it's happened again. I'm right back where I started. It feels like these last 3-4 months have been for nothing. How do you then help the patient deal with that?
So I would do what is called a preempted strike in martial arts. I did martial arts for something like 13 years.
Mm-hmm.
So basically, a good clinician should anticipate that there will become dips and flare-ups, and they should prepare the patient to have a plan B if this happens. Okay, so you have a flare-up or you have a dip, and now it's wrong. Try to sort of troubleshoot what was it happened that may have triggered the system. What did you do yesterday? What happened? Have you been severely stressed? Have you been pushing the limit even though you knew that you shouldn't do it? Have you been sleeping wrongly? Have you been loading up too much? Do you have have you been falling into the old habit? And most people, they actually do know what has happened, but they don't use this information to make better judgments, meaning an exercise you could do is using the DIMS-SIMS framework from DIMS, Danger in Me, SIMS, Safety in Me, from David Butler and Norman Mosley. And they could do what I like to call a DIMS and SIMS map. So it's a much more behavioral approach to the painful experience, meaning that they put all the things that they have two post-it notes. Actually, if I get here, so yeah, they have one of these or one of these post-it notes. So they write all the things that usually trigger their painful experience on the red notes and all the things that actually help on the green notes. And then they fill one side of the fridge with the painful Danger in Me notes, and then another side on the helpful or Safety in Me notes. So now basically they have sort of done a individual DIMS-SIMS map of all that sort of irritates that activates or facilitates the pain neuroattack, but also what helps them. It could be lying on the sofa with a pillow between my legs, or it could be doing a stretch exercise, or it could be meditating or doing mindfulness, or it could be walking in the forest, or it could be relaxing and viewing a movie. And then the painful events or behavior that activates the pain neuroattack, that could be going downstairs, or it could be sitting too long on a chair at work, or it could be, like we talked about before, running, or it could be doing gardening work or something.
Is there ever a fear that you can then cause the patient to become too pain focused with this approach, that you get them to write down all their pains, you get them to figure out everything that's happening, that they then start associating, like we mentioned at the beginning, with the person that runs and has pain? Is there ever a fear that you can potentially develop the patient to become overly pain focused?
Yeah, there's a danger. There could be a danger is that if it's done without a explanation that they themselves understand, meaning that actually there's nothing wrong with having the pain. Focus should be that pain is actually normal, and pain in most cases actually is good, because it facilitates rest and it facilitates restitution, meaning you rest and you don't. It's like if you have cut your finger, then of course you will get inflamed and you will get painful in the area and also the surrounding area. But that's a good protective response, meaning it avoids you cutting the finger again in the same place, or actually it also avoids you making a small cut into a large cut, because you get a warning when you start to cutting the finger. So actually it reduces the amount of injury, and it also promotes rest, and it promotes healing through rest. So pain in most cases is a good thing, and the solution and the purpose should never be to be totally pain-free, because that's also not a good option. We should be able to have a well-functioning warning mechanism. We should be able to put our hand on the stove and get told that that is not a good idea.
I suppose in the same vein, it's also a good idea to explain to the patient that pain doesn't necessarily always equate to tissue damage. It's not always one-to-one, right?
So, and then you can use a number of different metaphors for in explaining this lower threshold. So basically, you could explain it by the example I gave before about the cut in the finger. So basically, the tissue is, you could call it irritated, or it's sensitized, it's extra sensitive in not only where the cut is, but also the surrounding tissue. And that's a good thing, because then you are extra focused and you are extra guarding that area. But in some cases, even after the tissue are healed, this guarding effect can persist. The psychological adaptation towards the injury is still there, but the injury is actually healed. Does that make sense? Basically, that could be one of the reasons why people have pain in the back years after they had a discus prolapse. So they may have some tissue damage. And some time ago, they had some severe tissue damage. They got it confirmed. Now, of course, that could be influenced by a multitude of factors also, but they had an injury. I had one patient who, she was out in the forest riding on her horse, and she fell off her horse, fell down onto the stump, and she landed on a stump with the low back. And now she had chronic pain for 10 years in the low back. But she could do everything. She could jump, she was as structurally sound as possible, but she would get these attacks of pain and have severe pain that would totally almost paralyze her. She couldn't do anything. She had to just lie down. But clearly, her back can't be totally broken one day and then week after she has no problems, and then it comes back. But this sensibility, this sensitivity modulated by a multitude of factors is part of the problem.
Where does your clinical experience come in to your decision making then with these sorts of patients? And I know clinical experience is a recent hot button topic for you as well.
Let me preface this with saying that clinical experience is of huge value, but in one instance, it doesn't have that value that most people think. So basically, where I go on the fence with clinical experience, if we are using our clinical experience to make causal claims, meaning that we can't, from our mere experience, show that there's a causal relationship between what we do, our intervention, or the patient's pain. We have to look at research for this. So when it comes to causation and showing causal links and causal inference, we can't use our clinical experience or what we see in our clinic. We have to use research for that. And what we do with our patients should be supported by a view and informed by what the research says. So we know that we have a tremendous amount of research supporting the fact that sleep, for one instance, a major contributor and a major modulator of pain. So when a patient comes and tells us that actually their sleep impacts their pain, then we can believe them. The believability and the plausibility behind that claim that they are making is much more trustworthy because it's validated by research. And we have to use this in our judgment. How trustworthy is the factors and the story that they are telling to us? Now I'm using that internally in my clinical reasoning. I'm never going to tell a patient that isn't so, but some claims can be highly dubious, and they can also, and some beliefs can actually not be helping, but doing the opposite towards our patient goals. Like believing that pain has to do with the body, that makes them not look at all the other stuff that could actually potentially be helping them. The belief that pain is always about the tissue paradoxically makes people not look at other factors that could be helping them. So if you have a firm belief that, like one patient had, that he had the firm belief that the only solution to his back pain were that the medical research scientist should invent him a new back because his back were broken. And from that standpoint, his only solution was to get a new back. But that, of course, also makes him blind towards the fact that a lot of other potential factors could be impacting his pain, and also the solution that there is in looking at those factors.
I suppose what you're getting at is that without the evidence behind it, we shouldn't say that for patient 1, 2, 3, and 4, because treatment method A worked on patient 1, I'm just going to take that, rinse and repeat it for patient 2, 3, and 4, right? Because you've got no evidence to show that. However, where does the innovation then come in? Because the things that are shown within the evidence have all come from someone seeing a pattern and saying, hey, actually, this method of treatment worked. Let me take that further. Then they then went on to study it. But they then had to make that initial link first.
I see the point you're getting. So I would preface that by saying we can never show something works in the clinic. So the question that is often raised is, it begs the question if it did in fact work. We can't show it worked. So a great paper on this is a paper by Herbert et al., which states that outcomes measures outcome, not effects of intervention. That's basically the title of the paper. Meaning what we measure in the clinic is outcomes. And outcomes are influenced by a multitude of factors, not only our intervention. So we're actually seeing the end result in the clinic of all the factors together, not only the thing we're doing to people. That is why we need research to show causal links. And often what I see as we are doing what we think is innovative is doing something new and something more. But often, and this was paraphrased by Professor Marr, Christopher Marr, that actually what would be highly innovative in the world of physiotherapy right now would be stopping to provide ineffective and unnecessary care. So innovation from my point of view is not doing more, it's actually doing less. And often many physios are in a never-ending search to find new tools to put in their toolbox, but they never stop up to ask if the tool actually has high enough value to be in the toolbox in the first place. So what I recommend on my courses is, and what I try to do is actually taking the toolbox, tipping it down, putting all the tools out on the floor, and then only putting back the tools that actually have high value. So we have a very much a bit too big tendency to saying yes to every treatment, new treatment. It's exciting. Let me do this. This is something I can add. But actually, that's not why. You can't increase the quality of your treatment by saying yes to all treatments. You increase the quality of your treatment by saying no to all the low quality treatments. So basically, being innovative, we should not only do more, we should also do less. And often innovation is not only, and very seldomly happens at the clinical side, but it often happens in the research side also, meaning that we test our hypothesis and actually our finding didn't show what our hypotheses were. Then we have to innovate and make a new model based upon our new findings. And a lot of these innovative solutions are sadly not being used. There's, from my point of view, there is a wealth of research-based knowledge that could inform our decision making that we are not using.
Such as? Have you got any examples?
Oh, well, my course is around 300 references in my literature review. So the summary of all that research, I feel, could lift up physiotherapy and could increase the quality tremendously.
Are there any quick hits that you could give us now that you could explain for the listeners?
So quick hits could be, or quick tips could be, if I find in my clinical practice, I get a patient with a new diagnosis, then I basically try to look at the research and the etiology of the disease. What is the cause? Is it caused by something? What does research dictate about this disease? So basically, I try to look at the given research. Then I try to find out, and that's where I use my clinical judgment. How applicable is this research towards my patient? Sometimes it is not that applicable, but often it is. So if the patient has been diagnosed with the disease, then knowledge about the disease will better the quality of my judgment. Knowing what is potentially causing the disease will increase the quality of my judgment. And in most cases, we have research, but we're not reading the research. That's actually the main problem.
Okay, but then what would you say if you had someone who comes in with a disease that you know quite well, or an issue, disease, or an MSK problem, what have you, but it just doesn't present the normal way that you would expect it to present? Now, your research has dictated you should treat it in method A, but the research hasn't seen it when it presents in presentation X. Now, that for me is where your clinical experience is really important, and where you differentiate. And it's a discussion I had with Kai, actually, where you differentiate between the people that have only read research and are really good when you put the textbook definitions in front of them, and then you get the people that can look at the research and, like you said just now, see what's appropriate for your patient. But then if it's never occurred in the research, then essentially that person is then stumped when presented with something that the research hasn't covered yet, that the research hasn't shown.
That's from my point of view, that's a common error and a misrepresentation of what evidence-based practice is. So evidence-based practice is not only looking at random controlled trials and doing what they say we should be doing. That's not evidence-based practice, and that's from my view an utopia. So evidence-based practice is not looking up a randomized controlled trial with shoulder patients and giving them the exact same program that was used in the trial. It can be that, but often it is not that. So evidence-based practice is taking all of the knowledge about the given area, dissecting that, and then making a clinical judgment using the best external evidence in combination with the patient's needs and goals, and integrating them with your clinical experience. So that's basically Sackert's approach to evidence-based medicine. So evidence-based medicine is never only clinical experience. It's never only patient preferences, goals, and needs. And it's never only research, but it's those three things combined. It's a unity. I call it, what's it called? Not tri-unity, it's called something religiously.
The Holy Trinity.
Yeah. Exactly. So basically, evidence-based practice is like the Holy Trinity. It's three things combined. Evidence-based practice is only when those three things are combined. You have all the external knowledge, you have the patient preferences, and you have your own experience. But it should also, and Kenny Ver, a very great physiotherapist, has a great article on this. The different areas are good for different things. So basically, evidence-based medicine is not cookbook medicine. It's not just you're a dummy, you're just doing what the research says. That's not evidence-based medicine. And evidence-based medicine, the research, it needs the clinicians, because the clinician is the guy or the person analyzing and judging and using his clinical judging in the applicability and the way of integrating the evidence and making it fit the patient, if we can say it that way.
That I'm more on board with, but I also feel like that explanation is a little bit different to what you just said of running it by the research only. This kind of brings into it the fact that you have to then look into the research and discern what's applicable, and then look at what from your experience and the patient's experience has also been applicable.
Yeah. So I could preface this a bit with saying what I started to say, that in my view, clinical experience is of high value. It has a tremendous amount of value, but often it's used on one particular point the wrong way. And that wrong way is when it's making causal claims and trying to find causal connections. We can't. That's why we need research. And it's really, really sad that physios and many other health professionals, do not know how much they actually need research, but research also need them. Research doesn't help people. Clinicians help people. Our clinical reasoning helps people. The skillful application of the research is what helps people, and only clinicians can do that. Evidence is a piece of paper. Patients can get that research through the internet, easy, but that won't help them. It's the skillful application of that research using skillful clinical reasoning that helps people, and that's the clinician's role. So like I said before, it's like a unity, but my main problem is when we try to use our experience for something it has no value in, and that's making causal claims. So basically, we should use research for what research is good at, and we should use our experience as what it's good at. Both things have high value, but many physios, and there are sadly a lot of papers showing this now, evaluate research because they think they don't need research. But we need research, but research also needs us.
Have you got, coming back to the pain side of things, have you got any particular reading recommendations that you think might be useful for someone who wants to get more read up on this? Because it seems like there's a lot there and there's a lot to decode.
So I have some posts regarding this on my website, but what I would recommend right off the bat is reading a textbook for health professionals, the second edition. That's a really good introductory textbook.
What's the name of it, sorry?
It's a textbook for health professionals by Hubert van Drievensen and editors. I think 2 seconds.
Ah, lovely. It's there to hand. Nice.
So that's the book I would recommend. And then you can go into other aspects. There are multiple other books that I could recommend also, but that's a good introductory book on pain.
All right, lovely. And you mentioned that you had some posts about it on your website, right?
Yeah, so I have on my website, larsavemarie.com, I have 10 book recommendations, and I also have 10 recommendations of essential scientific papers in pain management. And then I have a multitude of free articles, mainly about critical thinking, clinical reasoning, and pain science or pain research.
Can you share some of your own personal learning moments then during this pain science discovery of journey that you've been on? Some learning moments with your own patients?
So basically, the best success stories I've had with patients and patient interaction is when I quickly and to a great degree gained a great deal of therapeutic alliance with the patient, and we had a mutual goal we could work towards. I eventually actually had a patient having what you could call a different representation of a hip fracture and hip operation, and she was finding it very, very hard to make sense of this painful experience. And because she didn't have a usual representation of a hip fracture, she was referred back to the orthopedic surgeon, and because he did not, or my estimate is that he were not really that good in gaining her confidence, she actually sort of yelled to him that they should hire me instead. Because if I had worked there, I would never let this happen. So that's a case of having a so firm therapeutic alliance that it almost affects your co-workmanship with the surgeon in a bad way. Because of course he was really not happy to getting to know that he were not good at his job and I were much better, and she actually did not trust him. She only trusted me.
I'm sure they loved hearing that.
In this case, I also had a great deal of rapport with her, and I truly wanted to help her. So that is some of the best examples where you truly or the best success stories in the interaction with people with pain, where I really tried to understand the patient, but also that they felt understood. A really what do you call it? A
Mutual understanding between each
um,
other.
mutual understanding, but also talking with them as not as they are your peer, but as they are of equal worth. And a little bit back to what we talked about earlier, that you really truly communicate to them in a sincere way, and you should really feel it, that you want to do everything you can to help them.
Okay, so this is more a success story where, because you developed such a positive rapport with this patient over however many treatments, that the successful outcome was come to, the successful outcome was reached.
Yeah.
Yeah.
So basically, in this case, it were the successful outcome were helping the patient feel listened to, but also helping them deal with the situation that they were in, or helping them actually increase their quality of life in this case.
What about any learning moments that you have had?
So one of the biggest learning moments I've had and realization in my professional clinical life is that understanding that you can't help everybody. So you can't help everybody, but you have to try to help everybody to the best of your ability and help them in the most humanistic way using current evidence and current research. But also know that actually it's not our responsibility for our patient's outcome. But it's a bit like fishing, being a clinician. You can throw out the line, but it's the fish that has to bite onto the hook. But as clinicians, we should always try to do our best, meaning we should always throw out the line. But not every patient will get caught or grab the hook or will bite. So sometimes it's not actually you, it's much more about them. Maybe it's the wrong time, maybe it's the wrong way you were saying it, maybe they understood it the wrong way, maybe they are not at that place in their life at that instance, or maybe they are still looking for the quick fix. But I believe that as clinicians with a ethical and professional responsibility, we shouldn't give them the quick fix. I really firmly believe we shouldn't give them the quick fix. We shouldn't, by purpose, giving them something we know that does not work. But we should be skillful enough in our reasoning and in our professionalism that we can coach them and guide them towards a better treatment.
Yeah. Oh, great. And then how can people find you then if they wanted to find out more about you and your courses and stuff?
So there's basically my website, which were larsavemarie.com. That's the first, and then they can always follow me on Facebook through my name. So currently I am full up, sorry for the pun, full up of friendships, meaning that I have reached my limit, but you can always just follow me. And I post pretty much daily in the area of nutrition, science, research, pain management, critical thinking, clinical reasoning. So basically, I have a lot of posts surrounding that area.
Wow.
Yeah,
Didn't even know you could reach a limit on that, but yeah, no, that's great. So they can get regular updates from yourself in those different fields.
yeah, yeah. And if they really want to be, friends with me, then they can also often send a request. I like to what do you call it? Bump the boat,
From the
push the
oh,
boat,
push
and
the button.
or push the or challenge the status quo. I'm a firm believer that physiotherapy is great, but it could be much greater. And I try to push the envelope a bit. So sometimes people dislike that, and then they defriend me. So there are often spots becoming available.
You hurt their sensibilities
Yeah.
with
Yeah.
radical new ideas.
Innovative.
Innovative,
Yes.
yes, yeah. And you're also working on a course with ourselves as well, right?
Yeah, I am. I'm working on a big course that hopefully will be coming.
And that's modern pain rehabilitation, is it?
Yeah, modern pain rehabilitation, where I try to, through modules, cook down, what do we call it, reimagining how pain rehabilitation could be using current pain science and current pain research.
Okay, great. All right. Well, Lars, thank you very much. Really appreciate your time. Thank you for being able to put some time aside. And yeah, it was lovely to talk to you. Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time. Peace.